recording. I'd like to start off by acknowledging the traditional custodians of the land we're gathering on today and pay my respects to the elders past, present and emerging. Just a little bit of housekeeping before we get started. Please stay muted throughout the event. As I mentioned before, the webinar will be recorded. If you do not wish to be recorded, again, please just make sure that your camera and microphone is turned off. You might have noticed that the chat has also been disabled. So to contact me or to contact Emily, the speaker, then please send a message via the Q&A box. Questions are to be sent through the Q&A box and they can be sent at any point throughout the webinar. There will be time at the end for questions and those questions will be selected from the Q&A box. We will also be moderating the questions. Finally, after the Q&A, everyone is strongly encouraged to scan the QR code on the screen, which will be on the final slide, and to complete the feedback form. Just before we get into the presentation, I'll take a minute to introduce AOWA. AOWA is short for Arthritis and Osteoporosis WA, and it is a not-for-profit organisation that has supported people living with musculoskeletal conditions across Australia across WA for more than 50 years. Our mission is to reduce the impact of those conditions through education, evidence-based programs, research and advocacy. We work closely with health professionals, with researchers, with volunteers and with the community to help people better understand and manage their condition and to improve their quality of life. As part of this, we run initiatives which you can see on the screen. These include self-management programs, education, exercise classes, support groups, infoline services, rural rheumatology clinics, and also camps for kids and for young adults with arthritis. We also fund research. Oh, sorry, someone's got their microphone on. If you can just turn that off. We do also fund research and we distribute resources. I'm just going to mute everyone. There we go. Our services are available to individuals around WA. So if you're looking for more ways to provide your patients with education, with information or support or other social connection, then I would encourage you to have a look at our website or direct them to it. We can send resources and information out to your patients if they request them, which they can do by either calling us or going onto our website. And we're also here to talk to them about their situation and provide education about and for their condition. Some of the services that we provide that are particularly relevant to you are, of course, our health professional education sessions like tonight, where experts deliver education sessions to upskill other health professionals. We also have Atlas, which is a free online e-learning program to upskill health professionals about evidence-based practice and treatment for osteoarthritis and rheumatoid arthritis. Aside from that, we send out e-news and magazines so that you can stay up to date with emerging research, upcoming sessions and opportunities. And if this is something that you're interested in, then please get in touch with us or visit our website. It's now time to introduce our speaker, Dr. Emily Calton. Emily is an accredited practicing dietitian, nutritionist and accredited sports dietitian with a PhD in public health. Emily is a senior lecturer and researcher at Curtin University and coordinates nutrition-related research at Fiona Stanley Hospital, Fremantle Hospital and Coburn Health. She teaches the latest advances in nutrition, including evaluation of emerging diet trends such as intermittent fasting. Through her telehealth practice, The Nutrition Doctor, Emily supports clients around Australia to make changes to their diets to improve their nutrition and to manage health conditions such as arthritis and osteoporosis. Emily has been involved in many health education activities with us, including writing magazine articles on the role of diet, presenting at seminars and events, and delivering education for health professionals on the role of diet. We're fortunate to have Emily tonight to present. Thanks, Emily.
Thanks for that introduction, Rihanna. I'm really honoured and feel really humbled to be invited to present this evening. I hope that you're all going to get a lot from this evening's PD event. If you're attending live or if you're going to be watching the recording. So what I'll do is I'll just share my slides. Okay, and I'll just do a quick check with Rihanna, you're able to see those?
Yep, that's good, Emily.
Fabulous, thank you. So in terms of what you're going to be getting from this clinical update session this evening, what we're going to go through over the next hour is talk about, well, what is the latest research on weight management in OA? So I've really focused in on what's happened mainly in the last 2 years in terms of updates with clinical practice guidelines and research studies focusing on systematic reviews and meta-analyses. Then we'll move into looking at perioperative nutrition interventions that are taking place. So either pre-surgery or during surgery or following surgery to enhance outcomes in individuals who are undergoing either hip or knee joint replacement. And then we'll move into something which has been really topical in a variety of different health conditions, which is the use of weight loss medications in OA. So we're going to focus in on the GLP-1 receptor agonists and really look at what is the research showing with the use of these weight loss medications specifically in OA. And we're also going to take a look and sort of zoom out and have a look at what research is showing in other health conditions as well, so that you can take away some important implications and overall take some practical messages for advice that you can be providing to your clients or your patients or your consumers. So the learning outcomes is it's really important to be able to support your evidence-based patient care or client care. So the 3 learning outcomes are to recognise, be aware of what the latest research is when it comes to weight management and also making dietary changes. So we're going to have a look at some specific dietary patterns in OA. Identify what the evidence is for perioperative nutrition interventions in hip and knee joint replacement. And this will help you to identify potential referral pathways or collaboration opportunities for you within your own practice. So whether you're working in private practice and you have dietitians that work within your clinic, or whether you work in the hospital setting and you have dietitians within your MDT team, or if you're working in a setting where you may not have dietitians within your practice, but identifying who are some dietitians nearby or that you could refer to. And then the last one is to be aware of the emerging evidence for the use of the GLP-1 receptor agonists in OA. And it is really emerging evidence. We'll take a look, and there's not there hasn't been a lot of research studies specifically in the OA population, and also to be aware of side effects or negative impacts that that your clients or patients may experience with the use of these medications. Oops. Okay, so why this topic this evening? So it's well recognised that obesity is a major risk factor for OA developing, and that's because of its association with not only adding to mechanical load that joints are under, but also the more adipose tissue that someone has, that changes the structure of the adipose tissue. And so more immune cells move into the adipose tissue or the fat tissue, and those immune cells and the fat cells themselves start to produce inflammatory proteins. So we see inflammation at the level of the adipose tissue, but those inflammatory proteins leave the fat tissue and go into the circulation, and then they can bind to receptors and influence inflammation at the local joint, whichever joint we're talking about. Also, we know that obesity is associated with poorer metabolic markers as well. So things like high glucose levels, things like low HDL cholesterol, high LDL cholesterol, high triglycerides. And the more of these metabolic abnormalities that people have, the increased risk of developing OA. So individuals with obesity are not only more likely to develop OA in the first place, they're also more likely to have more severe OA, especially when it comes to knee osteoarthritis. And this is because the inflammation that the adipose tissue is contributing to speeds up the cartilage damage. These individuals who are living with obesity are also more likely to need joint replacement surgery. And when they undergo surgery, they're also more likely to experience complications both during the surgery and also following the surgery, and have inferior outcomes as well. So they may need to have another surgery, and they also are at increased risk of having complications associated with other surgery types as well. So addressing obesity is one of the central pillars when it comes to the management of OA. This is widely recognised in majority of the clinical practice guidelines when we take a look at the international literature. So one of the things that we look at when we're looking at, okay, well, how do we address obesity? We've got psychological interventions, so through psychologists. We also have looking at diet, so through dietitians, looking at exercise, so through physiotherapists, exercise physiologists, for example, and we've also got the use of the weight loss medications, and the new kids on the block are the GLP-1 RAs. So we're going to focus in on those this evening. And also the very first meta-analysis examining the impact of different types of diets in managing OA has very recently been published. So we're going to have a look at what the results are of that meta-analysis. So if we take a look firstly at a study that was published in 2025, and they were doing a systematic review of clinical practice guidelines. So of the 15 clinical practice guidelines that were identified to relate to OA, weight loss was recommended for 12 of the 13 clinical practice guidelines that related to knee OA. For the clinical practice guidelines which related to hip OA, so there was 11 of those, weight loss was recommended in 10 of them. However, weight loss was not recommended in any of the hand OA guidelines. So there were 4 clinical practice guidelines that provided guidance specifically for hand OA. So a key takeaway message is that when we have a look at the clinical practice guidelines that are available around the world, majority of them do recommend weight loss for knee OA and also hip OA. So majority recommended weight loss, and only one guideline though specifically mentioned the prevention of weight gain. So what we know is that adults tend to accumulate weight as they move throughout adulthood. So this is a really common pattern that people put on weight. And so if we know that this happens, it makes sense that then the older that people are getting, the more common overweight and obesity is. And so it makes sense that rather than trying to target weight loss, we try instead and target the prevention of this weight gain happening in the first place. So this is really a missed opportunity. So it's a missed opportunity that can be targeted by having conversations with your patients or clients around the importance of maintaining and having a healthy lifestyle. So the importance of being physically active, the importance of appropriate portions, of eating a healthy, well-balanced diet, of eating from across the 5 food groups, okay, in order to minimize weight gain happening. So if we have a look a bit closer at this systematic review of the clinical practice guidelines, looking at OA care around the world, we have a look at, well, who is the target group for weight loss? Do the clinical practice guidelines identify who should be targeted? So if we have a look at the clinical practice guidelines for knee OA, the majority of the guidelines recommended that individuals who were overweight or living with obesity should specifically be targeted for weight loss. So not just everyone should be losing weight. 3 of the guidelines actually recommended that the target group for weight loss was only individuals with overweight, not who are normal weight or not living with obesity. So specifically the group who were considered overweight. And one guideline in NEOA recommended that it was individuals living with overweight or obesity who also have functional limitations. So not just overweight or obesity, but they also needed to have associated functional limitations in order to be the target group for weight loss. And one of the clinical practice guidelines did not identify who the target group was. And now this was quite a similar pattern for the clinical practice guidelines looking at hip OA. So 5 of the guidelines recommended that the target group for weight loss interventions were individuals living with overweight or obesity. And 2 of the guidelines recommended that the target group specifically be those who are living with overweight only, so not living with obesity. Again, one clinical practice guideline recommended that the target group be individuals with overweight or obesity, as well as having associated functional limitations. And one clinical practice guideline did not identify who the target group for weight loss should be. So then, so now we've covered off on knowing that the clinical practice guidelines in knee OA and hip OA recommend weight loss. And we've also covered off on who is the target group. So most often it's individuals with overweight or obesity. Now we're going to move into, well, what weight loss strategies, if any, have been recommended within the clinical practice guidelines. So firstly, there were no guidelines that mentioned the role of pharmaceuticals. So any type of weight loss medications or surgical weight loss. So you're thinking about your bariatric surgery as interventions to promote weight loss in patients with OA, with the exception of one guideline, which acknowledged that individuals who have a BMI of 40 or above, then bariatric surgery has a role to play in promoting weight loss for those individuals. Now, there was very limited details around specific strategies. So regarding the duration or the frequency or the intensity or the type of exercise or diet that should be followed. So weight loss was promoted or encouraged as a key message, but there was no very limited guidance around well, what behaviours would people be adopting in terms of exercise and in terms of diet, and characterising the exercise and dietary approach. And only one of the guidelines included strategies for, once the weight had been lost, well, how do individuals maintain that weight weight loss. And we know we've got level A, which is the highest level of evidence that says it's very difficult for individuals who lose weight to keep that weight off. So majority of individuals lose weight and then they end up putting it back on. So this is really an area that individuals do need support around keeping that maintenance of weight loss. Also, now moving into weight loss strategies, specifically in guidelines looking at knee OA. So there was a combination approach of both diet and exercise, which was recommended most often by the clinical practice guidelines. So 4 of the knee OA clinical practice guidelines recommended a combined approach. One of the guidelines recommended exercise only, and specifically aerobic exercise to facilitate weight loss. One clinical practice guideline recommended exercise, but there was no further information around the exercise approach. One guideline recommended exercise and diet changes were optional. And then 3 of the clinical practice guidelines did not report these strategies to lead to weight loss in individuals with knee OA. Okay, so we can really see that there is a lack of guidance around specific dietary approaches and exercise approaches. That really, leads to the importance of working with the individual and tailoring the advice to exercise that they feel comfortable with. That is not going to be I'm just trying to think of what the word is. That's not going to be overwhelming to them, and that where they are doing the exercise is a comfortable and supportive environment for the individual as well. So the importance of tailoring the exercise approach that is recommended, and of course taking into account, for example, any pain, any other conditions that they may have, and exercise history to reduce any risk of injury and to promote safe exercise. So one guideline did describe examples of strategies to promote weight loss in knee OA. So the strategies included increasing physical activity. Compared to what was habitual for that individual. In regards to diet, what was recommended was following a structured meal plan. So where there's ideas for what individuals would have to eat across different points of the day. So whether they're having breakfast, lunch and dinner, or whether they're going to be having snacks in there as well. So there's a structured approach that they follow. One guideline also spoke to limiting portion size. So, messages around, what an individual is currently eating, looking at just reducing the amounts that are consumed at each of the meals. And then this same guideline also included strategies around nutrition education and promoting education around what are healthy food habits, what does a healthy diet look like, and then also some skill building, such as like label reading, for example, choosing healthy takeaway options, convenient snack ideas. So in terms of the degree of weight loss or the size of the weight loss or the target amount of weight, majority of the clinical practice guidelines made no reference to the amount of weight that should be targeted. One of the clinical practice guidelines identified that 5% as a minimum should be targeted. And they also acknowledged that there was a dose response. So the greater the weight loss, then the more improvement in terms of symptoms like pain and improvement in physical function. And one clinical practice guideline identified that at minimum 5 to 7.5% of starting weight loss should be the target. So then moving into weight loss strategies specifically in hip OA. So again, what was most common was a combination approach of exercise and diet. There were 2 clinical practice guidelines that recommended this. And then we had exercise being recommended by itself, so not in conjunction with diet in one study, specifically aerobic. Diet specifically being recommended as the method for promoting weight loss in one clinical practice guideline, and 3 of the clinical practice guidelines did not make reference to any specifics around diet or exercise or what the approach would be in order to facilitate weight loss. So in terms of the degree of weight loss, so again, majority of the studies did not make any, majority of the clinical practice guidelines did not make any reference to how much weight loss should be the target. One clinical practice guideline recommended at least 5%, again, acknowledging that dose response relationship between the more weight that is lost, the likely the greater benefit in terms of OA symptoms and physical function. And one of the clinical practice guidelines recommending that minimum 5 to 7.5% of starting weight. So in terms of practical implications and conclusions, so most of the clinical practice guidelines for management of knee and hip OA are recommending weight loss, generally targeted to people with overweight or obesity. And given that obesity is a major risk factor for the development of OA, is more likely to lead to OA developing earlier, so in younger individuals, and also is associated with greater severity, particularly of knee OA, more likely to need surgery, and also results in inferior surgery outcomes. The prevention of weight gain really is a missed opportunity. So some education with your clients and your patients around the importance of maintaining a healthy weight through healthy lifestyle. So another practical key message is that weight loss is very difficult for individuals to be able to maintain. So encouraging ongoing support. So, for example, if they're working with a health professional to achieve the weight loss, that they continue working with that health professional in order to maintain the weight that is lost. So you can do some education around with your patients or clients around the fact that majority of people put the weight back on that they have lost, and the importance of active strategies to maintain that weight, importance of self-monitoring, for example, as well. So whether that's tracking behaviors, such as, tracking number of days of physical activity across the week, because we know that people tend to return back to their prior established habits, or tracking something, for example, like number of cups of vegetables that are consumed per day. So a way of tracking healthy behaviours. And we also have to think about as well the context of promoting weight loss in the context of potential harm that promoting weight loss can lead to for individuals. So there's research that is very clearly showing that when people set out to lose weight and they don't lose that weight, or they lose it and then they put it back on, and that creates that sense of failure, that this has potential for negative consequences. So it has the potential for individuals to then think negative thoughts about their capacity and to lose weight, and to also self-blame themselves for not seeing that weight loss. When we know that overweight and obesity, it's really complex. There's so many factors that contribute to an individual's weight, lots of psychosocial factors. It's not just a choice around people's exercise and food intake behaviours. So we really, this is just acknowledging that what drives weight gain for people is often multifactorial and also highly complex. Also recognising that, in fact, research is showing that more than 50% of people who live with excess body weight or body fat experience internalized weight stigma. So they're taking on society's negative messages around weight. So they are judging themselves, being critical of themselves. And we know that this weight stigma has got negative consequences on health, increases mortality, independent of the effect of weight. So this weight stigma is a real issue that affects people's health. And also people can, in an effort to lose weight, they can adopt unhealthy or maladaptive strategies to achieve that weight loss. So for example, they could be setting up a diet and binge cycle, or excessive exercise, or not eating food at all, and then the individual is not only perhaps eating less healthy foods some of the time, then by not eating, they're not getting nutritious foods. Okay, so being aware of those. So now we're going to move on, so away from our clinical practice guidelines, which we're looking at OA and body weight and weight loss, and we're going to move on to looking at a systematic review and meta-analysis which examined the impact of weight reduction on OA symptoms. So this study was published in 2025. It only used RCTs, and what was found was that a weight reduction of 7.4% of starting body weight was needed as a minimum in order to lead to significant pain symptom improvement, and also to improve physical function as well. So this is a key message around some individuals will get overwhelmed with this idea of having to lose a lot of weight to get down to a healthy body weight. And a message here is that they may not need to lose that large amount of weight in order to experience some pain relief and physical function improvements. Okay, so this is going to have meaningful improvement in terms of quality of life. So for an individual who is 120 kilos, 7% of their body weight can look like 10 kilos of weight loss. Okay, so that can be something that you recommend, or that you educate your clients or your patients on, is they don't necessarily need to get down to a normal body weight. If they are losing that 7% of body weight, then that may lead to significant improvements for them in terms of their pain and physical function. So moving on now to the systematic review and meta-analysis, which examined the impact of diet, so various dietary patterns on OA. So this was published last year as well, in 2025. There were 9 RCTs which were included. And of these RCTs, different dietary approaches were examined. So there was a low energy diet, or a reduced energy diet. So that was the most common dietary intervention. And there were different methods used to achieve this reduction in energy. And also the diets varied in terms of the degree of the reduction in energy, but just grouping them together, we can call them reduced energy diets. The Mediterranean dietary pattern, so 2 RCT studies looked at this dietary pattern. A low-fat dietary pattern was examined in 2 studies, an anti-inflammatory dietary pattern in 1, a low carbohydrate diet in one, and a plant-based dietary pattern. So this was a vegan dietary pattern in one study. So they were the intervention groups. The control group, or the comparison, varied across the different studies, and it included individuals just following their usual diet. So that was most common. And then a low calorie or low energy diet was the control for one study, and health education sessions covering different topics were another control group. So overall, the low energy diets or reduced energy diets led to a large and a significant improvement in pain and also physical function. So this was where the strongest evidence was. So around lowering the overall energy or calorie or kilojoule content of the diet compared to an individual's usual diet. The anti-inflammatory diet showed promise as well. So there was significant improvements, and the improvements were large in relation to pain and physical function. However, there was only one study that examined the anti-inflammatory diet. I mean, overall, we can see that the number of studies is fairly low. So this is an emerging area of research examining the impact that diet has on OA, in terms of RCTs anyway. So a key message is that we need more dietary studies in OA. If anyone wants to do a PhD, please, or Masters by Research, feel free to reach out. And also the reduced energy diets. Of all the dietary patterns, reduced energy diets show the most effectiveness. So this is sort of a visual figure showing those results. So this is the meta-analysis looking at the impact of the different dietary interventions on pain as the outcome. So the most common dietary intervention was the reduced energy diet. And so the reduced energy diet resulted in a statistically significant improvement in pain. And then we can see that the anti-inflammatory diet also resulted in a statistically significant improvement in pain, but we've only got the one study there. So we really need more than just one study to be confident in recommending this dietary pattern. However, an anti-inflammatory diet in the context of, of health and potential harm, an anti-inflammatory diet is typically characterized by the inclusion of healthy foods and low intake of your ultra-processed foods. So examples of anti-inflammatory foods are a high intake of fruits and vegetables and whole grains, as opposed to your ultra-processed foods like your microwave meals, for example, and packaged and processed snacks. Okay, so in terms of looking at now just the visual of the results on physical function, again, we can see that the reduced energy diets, there was the largest number of different RCT studies looking at the impact on physical function, and then just the one study looking at the impact of the anti-inflammatory diet on physical function. But a key takeaway message is that reduced energy diets improve physical function and also pain, and perhaps also anti-inflammatory diets as well. So that could be something that you're recommending to your patient group or your client group. And in terms of practical strategies around recommending reduced energy diets, you could recommend that your clients or your patients reduce their portions that they're eating from their meals. So they might reduce them just a little bit, and that will achieve a reduced energy diet. And then a question that often comes up is people ask, well, what's the most effective diet when it comes to weight loss? So they also did a meta-analysis looking at the impact of the different dietary interventions on body weight. Limitation of this is it's just looking at the impact on body weight. And what we know is that body composition matters more than body weight. So unfortunately, they weren't able to do a meta-analysis looking at, well, what's the impact on fat loss? That would have been the ideal approach, because we don't want people when they're losing weight to be losing muscle mass. So in terms of the interventions which were effective for weight loss, just about all of them were, apart from the low carbohydrate diet. So the reduced energy diet was effective, led to statistically significant improvements in body weight or reductions in body weight. A low fat diet did as well. The Mediterranean diet did, but there was only one study looking at the outcome of body weight, and also the anti-inflammatory diet resulted in statistically lower body weight as well. Okay, so a number of different dietary interventions. Mediterranean diet is a well-established healthy dietary pattern. So that could be a dietary approach that you do recommend. So we'll now move our focus away from looking at symptom improvement in terms of pain and physical function, and move to looking at our systematic review and meta-analysis, which examined what's the impact of perioperative protein or amino acid supplementation for knee or joint replacement. So what we know is that malnutrition following these surgeries is very common. We also know that individuals experience significant wasting of their muscles. So significant wasting, for example, of the quadriceps, and also significant weakness following these surgeries. And the weakness has been reported to persist not just in the short term, but for up to 5 months following the surgery, which compromises balance and their independence and functional capacity. So the aim was to evaluate the effectiveness of perioperative protein or amino acid supplementation. So the supplements could be either provided pre-surgery, within or during the surgery, or post, on muscle mass, strength and functional outcomes in these patients. So there were 19 studies, which is a reasonable amount of studies. Some of these had fairly low numbers of participants. And so there were 12 studies which looked at hip replacement, 6 studies which looked at knee replacement, and 1 study focused on or included patients who underwent either hip or knee replacement in the 1 study. So 14 of the studies used protein or amino acid supplementation taken in through the oral route, and 5 used IV supplementation. 6 of the studies used essential amino acids as the intervention. So, for example, leucine as a specific protein. Specific amino acid, and 2 studies used whey protein as a specific type of protein, and the remaining studies used various other types of either protein, so other protein sources, or amino acids. And the average follow-up time was about 2 months, but the studies did vary. So the longest went up to a year, and the shortest was a 1-day intervention. So the findings were, majority of the studies that were included in the meta-analysis took place with participants that underwent knee replacement, and only 2 studies that underwent the hip replacement. But protein and amino acid supplementation did reduce muscle wasting. So it did that by enhancing synthesis. So either what can happen is the resynthesis of protein can be increased, or what can be decreased is the breakdown of protein, or a combination of the 2. So the supplementation worked by enhancing the rebuilding of the protein involved in the in the muscles. So the strongest effect was also seen in studies which had where the patients were undergoing knee replacement rather than the hip replacement. Okay, so a key takeaway message is that the use of protein or amino acid supplementation may help, particularly in patients undergoing knee replacement as an intervention, something that you can recommend or reinforce that your patients or your clients have an adequate intake of protein in the lead up to the surgery and then also following their surgery as well. So in that 5-month period following the surgery. So you can talk about and advocate for your patients or your clients, making sure that they're having a protein source at each of their meals, whether that is a plant-based protein, so like your legumes or your lentils or tofu or nuts and seeds, or whether it is your animal-based protein. So for example, you've got your high protein yogurts, and then you've got your chicken and your fish, and prawns, seafood, and red meat as well as other protein sources. So having a look now at the use of a pre-operative weight loss intervention before patients undergo either total knee or total hip replacement. So this was a systematic review and meta-analysis. Again, they just looked at RCTs. And their aim was to systematically review all RCTs that underwent these joint replacements. The intervention group received weight loss interventions, and the method of weight loss intervention could be either non-surgical, so diet, exercise, psychological interventions as examples, or they could be surgical, so your bariatric surgeries. And the comparison was, or the control groups were standard care. Okay, so standard care was not there was no weight loss aspect to the standard care. So they looked at then the number of surgeries that had complications compared to the number of surgeries that did not have complications. And then they compared the number that had complications in the weight loss intervention groups compared to the control groups, which didn't have weight loss as a pre-surgery intervention. And they looked at the impact on the odds of complications. So they took all the different types of complications that could happen following surgery, and they put them together in order to create this composite one outcome variable. So what the results showed is there were 3 studies which were included in this systematic review and meta-analysis. So 2 of the studies had participants which underwent knee replacement, and 1 study had participants who underwent both hip replacement or knee replacement. So the first study was looking at a low-calorie diet, which was defined as 800 calories per day through the use of complete meal replacement products. So, an equivalent in Australia is like the use of, for example, like Kickstart or OptiFast or OptiSlim that you may have heard of. Combined with nutritional education, compared to the control group, which was no dietary intervention at all. So that was 1 study. A second study also made use of meal replacement products, but was slightly higher in the amount of energy that could be consumed that day. And that's because the meal replacement products were only used for lunch and dinner, and they could continue to have their normal food in the day. And the control group was a reduced diet compared to their usual intake. And then the third group was looking at bariatric surgery as the intervention compared to just general healthy eating, general weight management advice. So the key findings is that All 3 studies reported significant reductions in body weight and BMI before the surgery, so they were all effective interventions. There was no difference in the length of stay between those undergoing weight loss before the surgery compared to the control groups. However, there was fewer post-operative complications in the intervention groups that underwent pre-operative weight loss compared to the control groups. And this was a very significant reduction in the complications. So the limitations, though, was that there's only 3 studies which were examined, and all the studies were conducted in Caucasian participants. So that's also another concern as well. Okay, so we don't know, well, what is the impact of preoperative weight loss interventions on the risk of postoperative complications in populations of other ethnicities. And so this is an area of research that we need. So some practical implications is that together these 3 studies show that it's feasible, so it works in clinical practice, and the benefit that comes from using that waiting time while people are on surgery weight loss to undergo pre-operative weight loss interventions, because the evidence that we have so far is a strong effect of pre-operative weight loss on reducing surgical complications. Also, it's important to educate patients and clients when they're placed on wait lists around, well, what is the risks. So medical risks and surgical risks when undergoing surgery at their current weight. It makes the surgery more technically challenging, for example, for the surgeon, and also encouraging patients to reduce weight loss prior to the joint replacement. But the method is important as well. So promoting a healthy, balanced method in order to mitigate risks. Okay, so we're thinking about there. We're wanting to avoid any maladaptive strategies that might be used and ensure that they're going into a surgery with the best and largest amount of muscle mass that they can, and not already having pre-existing nutritional deficiencies and malnutrition. So there is clinical practice guidelines that came out in 2023 around pre-surgery targets for joint replacement in OA. So when it comes to recommendations around body weight or BMI or weight loss, the clinical practice guidelines acknowledge that obesity itself, so someone having obesity, is not a reason to delay the joint replacement surgery. They also recognise that it's important to have a discussion with the patient or the client when they're placed on the waiting list about the increase in surgery complication risk during and then also following the surgery. So that education is important, and that weight loss should be encouraged, and keeping in mind, though, that not all patients or clients will have the financial or social support available, or resources available for weight loss. Okay, so yeah, keeping that in mind. Also, recognising that patients benefit from the increased mobility and improved quality of life that the procedure provides. So that's important to recognise, and also involving patients in shared decision-making processes as well, so that they're recognised as a key part of the team. In regards to glycemic control, so there were some clear recommendations when it comes to glycemic control. Firstly, individuals who have high blood glucose levels or high HbA1c pre-surgery are at risk of poor outcomes, particularly if they've got poorly controlled diabetes. So that's important. So screening for diabetes is important because it is underdiagnosed, and looking at what the glycemic markers are. There is no agreed upon target for glycemic control that needs to be achieved before surgery. So it's all about improving glycemic control as opposed to achieving a set target. And also there was no guidance around, well, what glycemic markers should be used. Is it HbA1c? Is it fasting glucose? Yeah, either or both could be used. But the importance of improving glycemic control if it is poorly managed pre-surgery. So now we move into looking at the use of GLP-1 receptor agonists in OA. So this is a systematic review of preclinical studies and human studies. And there were 11 studies which were included. So 7 were conducted in either cell models or with the use of rats or mice. And then there were 4 studies which were conducted in humans. So the preclinical studies, which took place using cell models or the rats or mice, they used different types of medications. And the dose and the duration that these medications were used for in the studies varied widely. But they consistently demonstrated that there was a immunomodulatory effect, and it was dose dependent. So the greater the dose, the greater the benefit for lowering inflammation. So beneficial effects were observed with the use of these medications in lowering inflammatory proteins. So in the human studies, so there were 4 studies which evaluated the effect of GLP-1s. So one was a cohort study design, one was a post hoc analysis of an RCT. So they went back and analysed data. The RCT had been designed to look at a different outcome, but they had the data, so they looked at this RCT, and then 2 RCTs were examined specifically for this purpose to evaluate what the benefit was. So overall, when looking at the 4 studies, there was inconsistent benefit of weight loss on knee OA symptoms. But we have to recognise that there were only 4 studies. So key messages is that this is an emerging area. What, if any, is the benefit of GLP-1 receptor agonists in OA on symptoms? So we need more research in this area. Also, the other limitation is that because the research took place already in established OA, we don't know whether the benefit is likely to be greater in those who don't yet have established OA. And also, all 4 studies looked specifically at knee OA. So we've got no studies looking at, well, what is the potential benefit on OA symptoms for other OA types. So in terms of practical implications, so if we take a sort of zoom out and if we take a look at what studies show looking at the use of the GLP-1 RAs in other health conditions, we know that not everyone experiences weight loss who uses these medications. So there's some emerging evidence that there are people who are non-responders. So people who require small amounts to feel full, they tend to see the weight loss, whereas individuals who require larger sized meals, larger amounts of food in order to feel full, don't seem to see weight loss with the use of these medications. Okay. We also don't know a lot about patients or clients' experience of the use of these medications. There's not a lot of research in this area. We also know that GI symptoms are common. So nausea, for example, vomiting, and depending on the type of medication that's used, diarrhea or constipation. So this can impact on people's quality of life, but also impact on their ability to eat nutritious food if they are feeling not well and they're experiencing nausea or vomiting. Okay, so there's potential for their nutritional status to be compromised. We also know that individuals tend to who lose weight initially, the weight loss actually plateaus. They don't continue losing weight. We know that people who start on these medications discontinue them at high rates, and maybe this is because of the cost, the high cost associated with their use. We know that when people stop using the medications, that weight regain is very common. And we know also that the metabolic health benefits which are seen when people lose weight, when they put the weight back on, those benefits don't persist. Okay? And so the high blood glucose increases again, or the high triglycerides increase again, or the high LDL cholesterol increases again. We also know that individuals using these medications see significant amounts of muscle loss. And so this speaks to the importance of recommending resistance exercise to help offset some of that muscle loss, and also promoting a healthy diet which is adequate in protein, so having protein at each meal to help offset some of that muscle loss as well. We also know that individuals have got compromised nutritional status before they initiate these medications for different reasons. So it may be that they had a poor quality diet beforehand, and so they're eating lots of those ultra processed foods, less of the foods from across the 5 food groups. And we also know that the main mechanism with which these medications are working is to reduce appetite. So if people have got less appetite and therefore they eat less, then if what they are eating when they do eat is the less nutritious foods, then this is going to further compromise their nutritional status and potentially further compromise muscle status as well, and lead to further muscle loss. So some promotion around if you've got clients or patients who are thinking about using these medications or are using these medications, promoting the importance of a healthy, well-balanced diet with the protein at each meal and snack and resistance exercise in order to support that muscle. So evidence-based approach to obesity management, we can have a look at the obesity clinical practice guidelines. Different countries have got these. So our guidelines in Australia are currently undergoing review. Some of the examples of the most recent published guidelines have come out of Canada. So they were published in 2020. And it's important to recognise that not all weight loss is beneficial. So screening for whether there has been unintentional weight loss is really important, because this is a red flag for, is there an undiagnosed health condition that is occurring for that individual, which is contributing to the weight loss. Also, malnutrition is common, and also low muscle as well. Avoid making assumptions about health based on people's body shape or size. So not only about their health, so not assuming that, or because they've got overweight or obesity, that means that they must have abnormal health markers. So not making those assumptions, not making assumptions around, or because they've got overweight or obesity, they must have an unhealthy diet, or they must not do much physical activity. So this is known as weight bias. So just avoiding those assumptions, asking questions as you would for any other individual, regardless of body weight or size or shape or body fat level. Being compassionate and understanding, and using non-judgmental language. So you're not blaming individuals for their body weight, acknowledging the sort of how complex and the many factors that influence body weight. So just taking off some of that responsibility away from the individual. Also, obesity management goals or weight loss goals are broader than just focusing on weight loss alone. So monitoring, if an individual is interested in weight loss, monitoring other aspects as well. So monitoring for, is there improved function? Is there improved exercise behaviours? Is there improvement in metabolic markers? Is there improvement in healthy food behaviours and, intakes of across the 5 food groups? Is there an improvement in the amount of water that's being consumed. So the clinical practice guidelines also recognise that there is no single one ideal diet for weight loss. So a lot of patients will ask, what is the one diet? So you can do some education around. There is no one. There's no one magic bullet. There is no one ideal diet, and a variety of different dietary patterns and approaches could be appropriate for that individual. And really the best approach is one that is going to be culturally acceptable, using foods that that the individual eats as part of their culture, that's going to be affordable as well, that is going to be promoting their nutritional requirements to be met, so not cutting out food groups, for example, yeah, they're sort of key takeaway messages. So I just want to finish up now, and as we move into our Q&A time, with what is the difference between a dietitian versus a nutritionist. So anyone in Australia can call themselves a nutritionist. You do have a university qualified nutritionist versus anyone in the general public that can call themselves a nutritionist. And a dietitian is both a university qualified nutritionist and a dietitian. So a dietitian is the health professional who's qualified to give advice when it comes to managing risk factors or managing health conditions. So if you're recommending a client or a patient see a health professional that's going to be giving dietary advice when it comes to diet, recommend a dietitian. So some take-home messages for you is that most clinical practice guidelines for the management of knee and hip OA are recommending weight loss, generally targeted to those who have overweight or obesity. Preventing weight gain during adulthood is a missed opportunity, and so promoting a well-balanced diet, eating from the 5 food groups, and considering if your client or a patient is open to working with a dietitian, that could be a referral opportunity. Also promoting physical activity as part of that prevention approach. The evidence for GLP-1 receptor agonists is emerging with OA, and the evidence in other health conditions shows that their use is associated with muscle loss and compromised nutritional status due to reduced appetite, and therefore less food intake. So to counteract that, promote a well-balanced diet, eating from the 5 food groups, and then consider referral to a dietitian for personalised advice as well that will assist in addressing what's the root drivers of obesity for that individual, and also promoting resistance exercise to help combat that muscle loss. To enable shared decision making, then some education with patients or clients around the risk that comes from having a elevated BMI prior to surgery, and considering referral to dietetics or to exercise if they'd like some support with weight loss prior to their surgery. Okay. Also being aware that post-operative malnutrition and muscle loss and weakness is very common after these joint replacements, that they compromise balance and functional capacity. So supplementation with protein and amino acids may help to reduce this muscle loss. And being aware that patients who have high glucose levels before surgery. They should be informed of those risks, and it recommended that they improve their glycemic control before they undergo their joint replacement. So let's move into our Q&A time. So there is a code up here that you can scan to give feedback on today's session as well.
All right, thank you, Emily, for taking us on such a deep dive into the current research around diet for OA and for joint replacements. We do have a couple of questions that have come through. I might start off with the one on GLP medications, as that's what we were just talking about. And the question is, how long should patients be on GLP medication for?
Yeah, this is a really great question, and a difficult question to also, to also answer. So we've only got some, and it's not much. We've only really got very limited studies looking at, well, what is the impact of longer term a use of these medications. So we don't have a lot of research evidence to actually sort of, I guess, govern this recommendation. So it comes down to who is the prescriber using their clinical judgment, having regular review appointments with the individual, and a key message is monitoring. So monitoring for any adverse impacts as well. So it might be, monitoring for any changes, for example, in muscle mass, and that can be, done through. It doesn't need to be something through like a DEXA scan, for example. It could be done through something like measuring a calf circumference, for instance, or measuring strength. Okay, measuring functional capacity. So that could be an outcome. But yeah, we don't have a lot of long-term data yet.
Right, thanks, Emily. If we move back to losing muscle versus losing body fat, a question came through about if a patient isn't able to exercise, how can we go about mitigating the loss of the risk of losing muscle if they're in a calorie deficit from a nutrition perspective?
Yeah, so there's been a number of studies looking at this. So if they're not able to do strength training, and you might look at, why they're not able to, is there a way to modify the type of exercise that they're doing? They might be able to do. So, for example, let's say they've had a joint replacement of, their knee or their hip. Maybe they could do upper body. Maybe that could be an option. So at least they're still using their upper body. But also taking into account that so you can limit sort of the overall muscle loss over the whole body, but being aware that then there will be some loss still happening in the lower body. So some examples from a nutritional perspective. So there's studies which have looked at different types of dietary interventions, and what helps to mitigate that muscle loss the most. So they've looked at high fat diets, they've looked at high carbohydrate diets, they've looked at high fiber diets, they've looked at high protein diets, and the high protein diet was the only dietary intervention that was able to mitigate the muscle loss. Some muscle loss still happened, but it reduced the loss of muscle that did occur.
Perfect, thank you. There was another one that I guess tied in a little bit to weight loss, which was why knee osteoarthritis patients are asked to reduce weight before the operation. I think you covered that, but the question was more about how they can't exercise because of the OA. So looking at it just through a diet perspective, how can they reduce weight, and why do they need to?
Yep. So, firstly, just targeting why do they need to lose weight before the surgery? There's I guess a whole variety of reasons as to why obesity increases the risk of complications during surgery, and then also leads to reduced positive outcomes following the surgery. So the reason for why lose weight before surgery is to reduce the surgical complications either during or post-surgery. And then the part of the question to do with, well, how do they then go about that weight loss? So it's about promoting where possible, and if an individual has got the financial resources, and depending on what healthcare setting you are working in, you may have a referral opportunity to be able to refer to dietetics, where the patient isn't or client isn't paying for anything because it's included within the service. There are, if your patient or client is private, and you're seeing them in the community setting, there is a bulk billing dietitian, which literally, if you go to GP and you type in bulk billing dietitian, it comes up with the URL. So majority of dietitians, however, don't bulk bill. So that's something just to be aware of. But there is that one that I am aware of who do. Care plans are also another example. So recommending that your patients go to their GP. If they're going to be having a joint replacement, then they'll qualify for a GP chronic disease management plan, and then that provides them with up to 5 visits per calendar year to see any allied health professional, but dietetics can be included within that. There will be an out-of-pocket cost if they're not seeing a bulk billing dietitian, so that's the only thing to consider. But Medicare currently provide a rebate of $61.80 to see a dietitian. It goes up by a little bit on the 1st of July of each financial year. Rebates are also available as well. So that just enables then the individual to receive some personalised advice, which helps to identify, well, what's the root cause of excess weight from a dietary perspective for that individual, and make tailored recommendations. But let's just say, that there isn't the individual doesn't have the financial support and resources. You can recommend websites like Dietitians Australia have freely available recipes. Live Lighter is another website which has got freely available healthy recipes as well. And also you can do some education yourself around with your patients or your clients around healthy eating from the 5 food groups. So you can recommend that your patients or clients don't eat less or reduce their intake of those ultra processed foods like your cakes, your biscuits, your alcohol, lollies, chocolate, and instead increase their intake from the 5 food groups. So like the fruits, the vegetables, whole grains. So whether that's wheat bix, wholemeal crumpets, red rice, black rice, quinoa, barley, oats, then lean proteins, so your like skinless chicken or prawns or fish. Canned fish is fine, as well. The nuts, the eggs, high protein yogurts, seeds, and then you've got your dairy or your alternative dairy food groups like your fortified soy milk and rice milk and oat milk. So you can recommend that your clients or your patients eat from those foods, and then they prioritize a protein source at each meal because protein is the main nutrient that helps to preserve that muscle. So recommending that they're having either the high protein yogurt or they're having the eggs or the chicken or the fish or the prawns or the red meat or the tofu at each meal.
Fantastic, thank you. If we stick on the topic of weight loss, how can we bring up this topic to patients? It's obviously a pretty touchy subject, and often people don't react well if they're told to lose weight.
Mm.
So what would be a good way to bring it up, especially if the patient doesn't say it themselves?
Yeah. So you can firstly you can ask for permission. So you can say, there's some evidence that shows that if we're talking about in the context of, say, surgery, there's some evidence that shows that weight has a relationship with surgical outcomes. Would you be open to talking about weight? Okay, so you can invite that permission. That's often a good way to start.
Great, thank you. Now, you spoke about anti-inflammatory diets before. If we just move back to that, I think a few years ago, gluten was definitely considered an inflammatory food. And there's a question here that there's a patient who's convinced that she's got to eat gluten-free because she heard that that was anti-inflammatory, but she's not celiac and doesn't have non-celiac gluten sensitivity, and also no issues with FODMAPs that she knows of. Is she doing more harm than good by avoiding gluten?
Yeah, so I think it's always important to ask people what about what they think gluten is. Firstly, gluten is a protein. A lot of people think that it's a carbohydrate. So asking, what do they think, gluten is, and just asking what foods do they think that gluten is found in as well. Because often people will just say, oh, it's found in bread and pasta, but it's found in a much wider variety of foods than that. And then doing some education around, well, what are the pros and the cons of limiting gluten? So we're talking about, with an individual who does not have celiac disease, because any individual that does have celiac disease does need to follow a strict gluten-free diet for life. For an individual who doesn't have celiac disease, just asking them around and talking to them about like I said, the pros and the cons of restricting gluten in the diet. So a clear con is that it is restrictive. So it limits the amounts, it limits the types of foods that they can have. It then reduces their food variety. It also makes eating out more challenging as well. So talking about and doing some education around the cons or the drawbacks of following a gluten-free diet, talking about what some other options would be in terms of anti-inflammatory diets. So you could talk about one of the nutrients that most promotes inflammation in the body is foods which are high in saturated fat, which is what is the visible fat that you see in meat. So you can recommend that individuals reduce that, remove the skin that's on chicken, for example. They choose low-fat dairy varieties as opposed to the full fat or the extra creamy milks. And other examples of saturated fat sources is anything that contains batter. So your croissants, your cakes, your biscuits, butter itself, and also your chocolate-based foods as well because of the cocoa butter. So you can recommend that instead people switch to reduce the saturated fat and therefore the inflammatory load of their diet. They instead switch to the low-fat dairies, the low-fat or high-low or skim milks, or the milk, the plant-based alternatives like the soy milk and the rice milk. And they're eating from the 5 food groups, so like your fruits and your vegetables and your whole grains. So that would be an effective strategy. So you could talk about that's an option as an anti-inflammatory diet. You'd also talk about the Mediterranean diet as another option as an anti-inflammatory diet. So just giving people examples and other alternatives, and recommending, well, perhaps trialing a different approach and tracking over a period of time. Does that have any impact on their pain, for example, or on their physical function?
Thanks, Emily. Last one. Do you recommend supplements? If so, when do you recommend supplements and what would you recommend? Perhaps you can talk about this both in the context of arthritis and also for joint replacements.
Yeah. So, clinical practice guidelines recommend, and also the dietary guidelines in Australia recommend a food-based approach where possible, because you get so many nutrients, and they're not non-nutrients. So by non-nutrients, I mean things like antioxidants and phytochemicals, or really health promoting substances in food that you just can't replicate in a supplement. So a food first approach where possible. The second thing is that supplements are not regulated in any way. So just because a supplement is available say on the shelves in a shop in Australia to buy, does not mean that it works. Okay, that provides any benefit. And there's also risks that come from the use of supplements as well. So they could be contaminated. So they could be contaminated with undeclared substances in the ingredient list. And there's been, a number of instances where medications have been assessed because health professionals or because individuals in the community have submitted an adverse event that identifies that they've had, for example, organ damage or liver damage, and then the specific supplement has been investigated and been tested and found to contain a prescribed medication, or a medication that has actually been pulled from the market because it's been shown to have significant negative effects or be carcinogenic. So there's risks that come with taking supplements, which is why so that's part of sort of an education opportunity as well. But they certainly do have their place if particularly if you've got an individual who's got is really compromised nutritionally. So for example, maybe they have they're an individual who has undergone bariatric surgery. And maybe so they've undergone a procedure that alters their gastrointestinal tract permanently. So they've got reduced ability to be able to absorb nutrients. And maybe they're, an individual who also doesn't have much muscle mass, and they've also got low appetite. Then they're compromised in their ability to get in enough nutrition through their diet. So that's a good example of where a supplement is important. But I'll also put the caveat of when people are using supplements and different types of supplements, they're not necessarily looking at, well, how much of this particular vitamin is in all of the supplements that I am consuming across all of the supplements and my diet. And that's where you start to see things like people having toxic reactions. So they might be having, excess vitamin A, for example, or they might be having excess, B6, which leads to nerve damage, and it can be permanent for in some instances. So there's certainly risks when it comes to supplements. Not an insurance policy of just use them just in case my diet is not enough.
All right, thank you, Emily. I think we'll wrap up the questions there. Thank you once again for taking the time to present. We so appreciate it. That does conclude the education event this evening. On behalf of AOWA, thank you everybody for attending tonight. A final reminder to please take a moment now to complete the feedback form. You can either do that by scanning the QR code on the screen, or I've also pinned the link to it at the top of the Q&A box. Please take a moment to do that now before you leave, as your feedback really does help us to better plan future sessions. If you would like to stay connected with us to hear about upcoming events and education sessions, or to learn more about how we can support your patients, then please visit our website or get in touch with us via email or via phone. Thank you once again. Thank you, Emily, and have a good evening, everyone.